Mr. O'Connor, dear Alicia, dear ladies and gentlemen. First of all, sorry, I just lost my mic here. Just need to fix it again. I would like to thank you for inviting me to give actually a speech on a topic that is very close to my heart. And I'm not just an employee of Janssen overseeing medical affairs for Europe, Middle East, and Africa. I'm also a physician with a background of infectious diseases. And I started as a student, later as a nurse working with HIV/AIDS patients in the end of the 80s, later as a medic then in the 90s. And I can tell you, if you have been in that spot, working at that time of deep crisis in HIV/AIDS, you get very passionate about access to innovative medications. So I'm very grateful to bring some points forward in the, I think, intense discussion about access to medicines. And I first of all would like to acknowledge that obviously the development of innovation and the adoption and implementation of innovation is really a complex, multifaceted issue. It's not simple, it's not straightforward. But I was asked today to actually focus on two aspects: the speed of innovation that we have seen, the impact it had on life expectancy, and then what are we looking at if we see the regulatory approval process and HTA and reimbursement processes. So these are the two aspects I will focus on. And I would like to first review some facts from the OECD. They looked at the impact over the last decade of various factors on life expectancy. And you see that just under 2 years did the life expectancy increase in a decade, which is a median, obviously, and quite impressive. And they looked at the contributing factors, and they identified that a significant part of this was actually driven by innovative medication. And if you go down then in more specific areas like cancer, if you look at that, and this is a longer time frame, it's from 1980 to 2008, so nearly 30 years, a lot has happened in cancer treatment. Again, we see an increase in life expectancy, and again, they calculated and estimated that a significant part of this, 83%, is actually driven by access to innovative medications. So I think quite impressive data. Now, I want to make that more tangible and give you some specific examples of even more recent innovations. So I selected a few drugs from various companies, and if you don't like that selection, please criticize me. Don't criticize the company, because it's totally subjective selection. But I felt it nice examples, and examples where I've been actually either watching the presentation or be involved in discussion. First, I would like to talk about solid tumors. And one of the most difficult ones is advanced melanoma to be treated. And I've attended the American Society of Clinical Oncology Congress in June in Chicago, which is, I think, not just an American congress, it's the biggest worldwide congress on oncology. And in the late breaker session, where really breakthrough innovation is presented for the first time, I picked a presentation for a drug that comes out of the new and emerging space of immuno-oncology. And this is a very exciting area, a new treatment approach for cancer, basically meaning we have now drugs available, two are actually already approved and on the market, that take off the plaque of the immune system that the cancer managed to put on the immune system to avoid being detected or destructed. So very exciting, novel approach. Very effective. Early data show impressive activity. And it was stated there, and these are really quotes, it's not me saying that, breakthrough in melanoma therapy should be considered new standard of care straight away. This is very much a medical position, of course. Interesting at ASCO was, for the first time this year, the whole agenda was not just clinical data, which it used to be. The significant part of the agenda was actually about value demonstration to the society and to the patients. So in the same session, the point was raised, great efficacy, but sorry, stop a moment. We need to evaluate still the value in terms of cost and associated benefits, which was quite a an interesting thing to see in a US Congress. ASCO has, in the meantime, because the HTAs are not the only ones who set up criteria for assessing value, the medical societies are starting to look at that as well. So ASCO has launched this year a set of criteria to define value from their perspective for new cancer drugs. And ESMO, the European Society of Medical Oncology, has actually followed as well. So we see a new emerging trend here as well. Hematological malignancies, we see breakthrough innovation all over the place now as well. I've chosen now one of the drugs from our portfolio just to exemplify this. This is for patients refractory chronic lymphocytic leukemia. It's a BTK inhibitor, ibrutinib, it is actually, it has shown in advanced patients basically an extension of progression-free survival. I will come back to that endpoint because endpoints are important in the discussion. Picking one example where I was involved much more also in the development, I don't show you HIV because you're probably familiar, but Hep C, I don't know, hopefully you have noticed the last 5 years, a revolution has happened. I've never seen something like this. In 2010 and 11, when you were chronically infected with hepatitis C and you were entering the disease stage where you needed treatment, then your treatment was based on interferon injections over a year plus ribavirin. And your chance of cure in hepatitis C, we actually talk about cure, your chance was 40%. So the chance of being cured with 1 year of horrible treatment, resulted in that many patients refused to be treated. Because if you are on interferon for 1 year, I don't know whether people in the audience who have undergone that, wouldn't be unusual. One of my closest friends has done that in 2006. It is a nightmare. Many of the patients have to actually stop working. And many of them are in our age, maybe really in a good stage of their career. And you can't just easily take out a year in your work life. Nowadays, we talk about 8 to 12 weeks of treatment, more than 96% chance of cure, and without interferon. So these are tablets now. So this is a massive transformation in a 5-year period. But what I would like to point out for the speed element, we have seen in this 5-year period, we've not seen one wave of breakthrough, we've actually seen 2 years. The first wave of innovation came in 2011. This is the first generation of direct-acting antivirals. In 2013-14, we saw the second wave that was so much better than the first wave that the first wave of drugs that was introduced 2 years ago was completely wiped out. So the first wave innovation had a lifespan of 2 years. Yeah? So that is an element I would like to highlight as well. These were not drugs that will stay for us. They are not used anymore because the second generation is just so much better than the first one. So I think very impressive innovation. I thought I choose that innovation in diabetes because we know many HTAs are skeptical about innovation in diabetes. And I can tell you, we have a hard time if you bring new drugs in diabetes in many with HTAs, not necessarily in Ireland or the UK, but I can tell you in France and Germany, you are facing significant pushback. Now, as a medic again, I was delighted to see data that came out, and my colleague from Boehringer Ingelheim is delighted probably that I show the data because it's their drug. But I said, and some of my colleagues said, oh, do you need to really show that? I said, no, we need to show that because it's a great point. It's a drug from the SGLT2 inhibitor class, and what that new class of drugs does is actually it cuts the reabsorption of excessive glucose in the kidney. So what you're doing, you excrete excessive glucose, you reduce the glucose in diabetic patients, so very from a medical point of view, very useful mechanism of action. It's not like insulin where you move glucose from one department to another in the body. What they actually were able to show, and they presented in the New England Journal, I think 4 weeks ago or so, it's the first time ever that they could demonstrate a reduced rate of hospitalization for heart failure, a reduced rate of death from cardiovascular disease, and an improved overall survival by reducing all-cause mortality. So I think this is impressive. And I come back later to the point, of course, these data are available only now. They were not available when we first discussed the value of these compounds. They were based on HbA1c, so they were based on a surrogate marker. And we got a lot of pushback from HTA saying, yeah, but we want to see solid outcome data from patient-relevant outcomes. The HbA1c is nice that your drug reduces it, but we want to see more. It's great to see for the first time that diabetic patients have actually a chance to experience a reduction in these relevant outcomes. One point here, pharmaceutical industry is absolutely clear. We continue to be committed to investing in innovative solutions. This is an analysis from 2012. More than 16,000 molecules mainly in cancer are in the pipeline. Of course, not all of them will make it, but it's a massive demonstration of the commitment of the industry to progress medical research in high unmet need areas. If you look at the pipeline, I would like to point out two aspects that are relevant for our discussions around value and value demonstration. Two examples from oncology, Clevex and Erbitux. We will see more and more drugs that have multi-indications, and as you go along in the time, this is where you have the market entry, probably in a smaller indication with a smaller set of patients, but the drug is of course developed in parallel later on in other indications. But this is the point where we currently discuss value. So if we see more of these products coming along, is the process of value evaluation and value definition, is it appropriate, or do we need a more flexible approach is probably the question, because we will see that more and more. The other aspect we see is actually that 42% of this pipeline molecules have the potential to be personalized medicine. Personalized medicine, you're probably aware, this is where you have a biomarker, companion diagnostic to your drug, and you can actually define exactly what patient will benefit from your drug and maybe which ones will not. It's actually more than 70% if you look at the cancer pipeline. So this is a big topic as well. I think there is a lot to do in the space of personalized medicine, companion diagnostics, because a lot of things are unclear, both in the regulatory approval process as well as HTA and reimbursement. Now, looking at some further facts, regulatory approval times of the 6 biggest regulatory authorities, you see here are the median approval times in days. So we talk about 300 to 4 up to 600 in the Chinese FDA now. We talk a significant of time we are spending in regulatory approval. This is, of course, median figures, and I will later talk about the advances made there. If we look at the HTA system that are asking us on behalf of the society to demonstrate value, it is clear that this is a legitimate request, absolutely. But I think from a medical perspective and an industry perspective, we have to prove value against a very diverse set of criteria. And I think that is something that we need to have a discussion on how we can actually come together. But in the absence of a European-wide agreement on how to do HTA evaluation, this is what we are faced with. Several national authorities define that. Sometimes, like in Spain, it's actually subnational agencies. You probably know in Spain you have to go to 17 bodies to demonstrate your value. If you look at the timings there, again, we talk about 300 to 500 days from marketing authorization to reimbursement decision. Actually, this analysis from IMS Institute for Healthcare Informatics, they actually also looked at the method used to assess value, and you can say actually they found that all the countries on the left-hand side who use the QALY approach have actually, for both non-cancer but even more so cancer drugs, significantly longer approval times than countries who do have chosen to go for other methodologies. So an interesting observation. I thought I include this one here, pre-approval access, compassionate use. It's not directly approval process, but this is where we are in. And this is a case from the US, the Josh Hardy case. If you don't know it, I would encourage you to Google. It's a fascinating case, 7-year-old boy after bone marrow transplant. He got adenovirus infection, needed a drug from Chimerix. Chimerix said they don't give it out pre-approval, and they started a massive social media campaign. And actually, the CEO got several death threats and was placed under armed escort. So it was about life and death here. And this is obviously something we're in the middle in. As long as these processes last, we are, as an industry, also faced with the challenge on how do we organize that, because we want to give terminally ill patients who have no time to wait, we want to give them access. A topic, maybe even a separate topic for a future meeting. So how do we do that in a more timely way? Again, acknowledging it's a complex issue. Patient wants best health, the healthcare system wants maximum health, industry needs commercial return. So in that space, I think we have to move forward. And a good example I would like to point out really is what happened in the regulatory space over the last 10 years. Across the globe, there are several mechanisms in the regulatory approval process of expedited review. So I think this we need to acknowledge has been a great advance on the regulatory side. I picked out a couple of other examples how you can approach and deliver more timely access. Examples from Canada and Australia is a parallel review. Yeah, so you submit to the regulatory authority. At the same time, you start negotiations with the healthcare, with the HTA bodies, and it's successful. So actually, Canada rolled it out for, as I understand now, for nearly all cancer drugs. Critical stakeholder engagement. I think Minister Lynch said it as well. This is complex, diverse interests. We need to come together, we need to discuss and collaborate together to move things forward. And there are several successful initiatives from the US and Canada, like the US Critical Pathway Initiative or the Canadian Excite Initiative, where you really, the principle is you bring all the stakeholders, and particularly also patient advocacy groups who are consistently either kept out of the discussion or not really heard, to bring everyone together from day one as you move along with your development. I think this is the most critical aspect ever, and I think a nice example that EMA has now set up is the so-called MAPS program. Adaptive licensing pilot is part of it, where actually you address this staggered approach of indications where you start small and then you get bigger, and you have these discussions and everybody on board early on. And we are looking forward to seeing how the pilot, how this is turning out. Of course, every part has to play. If someone doesn't play, it's not going to work. And we have to watch this, but the principle, I think, is a great one. Last slide here, basically, it can work. We've seen that this collaboration and stakeholder engagement has worked. It has worked, not in the HTA discussion we have now, but it worked in the 90s with HIV. It has worked with Hep C. Actually, we did it with Hep C. And if you look at last year, Ebola, all of the mechanisms that I described have been applied for Ebola to make, in that acute crisis, to move forward with treatments and vaccines as fast as possible, fast track, expanded access, orphan drug designation, all of this. So if you have a coalition of the willing, it can happen. So that's what I'm asking for, actually. We need more predictability, transparency of the process. We need enhanced collaboration of all parties, including patients, and we need that collaboration to start early at day one. And so I would absolutely echo what Minister Lynch said. You know, we have to work together, and then we can actually move. Thank you very much.
Thank you very much, Thomas. Well, now over to Professor Murray, Professor Wood, for comments or questions. Who wants to start? Professor Wood, maybe you would like to kick off.
Well, Dr. Stark, I'm fascinated with your talk. An excellent talk. As a physician who's also in the pharmaceutical industry, how do you manage the conflict on the one hand to the industry and on the other hand being an advocate for patient care? It seems to me you've balanced it quite well, but those looking from the outside might not consider it so. How do you manage that?
Yeah, it's a very good question, and I think it's a daily, to be honest, it's a daily, even also personal challenge, because you're an employee of the company, but you're also a medic. And so we are in this constant discussion. I think what I can say, what is important to me, that the medics are part of the dialogue. Yeah, dialogue internally in the company to represent the voice of the physician, the medical community, but also we partly represent patients at the discussion table internally, and then also be part of the discussion externally with the HTAs to bring that element. So the medical affairs function in Janssen is closely involved in not only the regulatory discussions, but also the HTA and reimbursement discussions. So for example, if we have discussions with the GBA or with NICE, it is our health economy colleagues plus the medical people going there to put the medical data into, and translate it into what that could mean in the way of benefit or value to patients, to demonstrate, to bring that medical aspect into it. And I've been myself in discussions in German, I'm German, I haven't mentioned it, but I've been in discussions with the German IPHA and GBA, and I have experienced firsthand how tough that it feels like you're in a courtroom, yeah, and you need to defend yourself. It's very uncomfortable. It's not, I would say, not an atmosphere. It's not a necessarily collaborative atmosphere, but I think we need to continue to push and keep that medical voice up. And that would be the role of the medics in the industry, I would say. In all of the, get involved in all of these discussions is for me the way to try to move things from our perspective. Thank you.
Yeah, Professor Murray.
Thanks very much, Thomas. I mean, one of the things that strikes me in relation to this is how bad we have been at breaking good news. In other words, those slides you present, which are slides that we know about, and the data about life expectancy being enhanced by healthcare, and particularly by the contribution of the pharmaceutical industry, I think that has been very poorly articulated. And in Ireland as well, where there's a lot of negative press in relation to healthcare, I think we as medics and as administrators, I think we've also failed to demonstrate that. And if you look, for instance, even despite a crash in Ireland, we've had an astonishing improvement in care for stroke, in care for cardiovascular disease, in care for cancer. And all of those things actually are using high value, very often high cost products. One of the things that strikes me is, as a liver doctor with a particular interest in hepatitis C, is how do we bridge that gap between treating disease and treating infection? So the way the products have been developed, and everybody knows it's been incredibly expensive. Like Mary Horgan, who's going to chair the next session, you know, I've been at those meetings and a participant in clinical trials myself, seeing it happen around us. But there's a deep frustration, I think, in the profession that the therapies are so incredibly expensive that they're utilized, and they're tremendous value, but they're too expensive. How do we think we bridge that gap? I know it's not quite to do with innovation, but it's to do with the consequences of innovation. How can we make it more affordable? For instance, the argument's been put that we should perhaps look at making pharmaceutical companies making similar amounts of money, treating more patients at a lesser cost to the health services. Because the cost of producing the drugs is pennies compared to what you've just described there. What are your thoughts in relation to that, as somebody with the background in infection?
Difficult question. I think your first point, have we been good in really explaining the value of the products or the molecules? I think that is something we can get better. I think we really need to translate data for people who do not necessarily have a medical background. I experienced that again, if you discuss with the GBA, for example, around the table, they're all non-medics, and you have no patients there. Now they have invited patients, but when I was there, so you're literally, and they invite some of the thought leaders or so to it, but you need to make a good job and a good point of what the value is, what it means for patients versus what is out there, first of all. I think this is very important. The pricing discussion, I agree, is a very difficult one, and it has driven lately with some of the very high price drugs has revitalized this whole discussion basically in cancer and Hep C as well. I mean, that triggered a lot also on the political level in Europe and the US. I would say taking one step back, if you do that, then you say what is, if you as a society are interested in medical innovation, because as a society you could choose not to be interested, and you say we're fine with where we are. If you're interested, then I know no alternative model to the farm industry to deliver that. And yes, we work in you could argue, in a capitalist environment, so we need to make a fair return to keep the machinery going. I think often it is also even underestimated what the industry takes as a risk, because out of these 16,000, maybe 50 will make it. So we take a high risk. You need to develop. This is extremely costly, and there is a fight now. How much does it actually cost or not? And you said manufacturing is often not the driving factor. True, it's the cost around it. But I would argue that farm industry is still the one place where you have all the expertise together to actually make it happen. We've seen in HIV, there are some interesting learnings. We saw again and again that NGOs told us, oh, you give us the drug with royalty-free license, and we develop it. I can show you several examples where this did not work at all, because they can't. Because developing a drug is a complex undertaking. It takes a huge infrastructure to move things forward. So I'm taking a bit of step back, because I have not seen an alternative model that in a cheap way could develop it. Even Bill Gates hasn't managed. I mean, Bill uses us as an industry to develop the compounds and the vaccines, because he acknowledges he has the money, but he doesn't have the infrastructure, nor does he have the expertise. I mean, that's my view, stepping a bit back on the pricing discussion. And if you talk about Hep C, I mean, you have drugs that transform the disease, and within 8 to 12 weeks, you have 98% cure rates. And you talk about cure. Now, if you talk about cure, how much do you think a drug that cures you can charge for? And of course, the challenge for us in industry is, to that question, we have to put a price tag on. And people don't like that you put a price tag on life or extension on life. It's a difficult I think, thing to do, but that's the position we are in, because we need the commercial return as well. So, sorry, lengthy answer, but that's a bit of my view.
Well, I mean, it's an issue that we could talk about at some further length. There's no question about that, but the clock has beaten us at this stage. I suspect maybe this is a theme that we'll return to, when we hear from some of our other speakers as well. But for now, I'll draw this particular phase of the discussion to a close, and our thanks to Dr. Thomas Stark, ladies and gentlemen, for his presentation.